right, we're back for the hospital panel. It is, don't look at that clock, my eyes keep going there. It's 11:25. I'm going to invite our co-chair of the Public Health Committee, Dr. Senator Dawood Anwar, to say a couple of remarks before we start with the.
Thank you so much to Dr. Gifford. Thank you for being a little late. I was in another meeting, so this is a very important part of the efforts that Office of Health Strategies is doing. I'm honored to be part of it. If we are back and forth between one meeting or the other, we are going to be listening into all of this conversation. This is one of the priorities that the governor has, the Office of Health Strategy has, the Public Health Committee has as well, to identify ways that our community, the people in the state of Connecticut, get the best quality of healthcare, but make sure it's affordable, and we have mechanisms to do that. So thank you for your leadership and the Office of Health Strategy leadership.
Thank you, Senator. Thank you for being here. All right, so we are going to move to our hospital panel. As you heard, we've invited two hospitals who are joining us this morning. We have the Hospital of Central Connecticut, part of Hartford Healthcare, that is represented by Dr. Jim Carden, and Yale Haven Hospital, part of Yale Haven Health, who is represented by Gail Koslia. Did I say your name correctly? Koslia, thank you. The panel will last about 60 minutes, and we are asking, as I mentioned with the prior panel, you can keep your responses to 5 minutes or so. We won't be strict about that, but just so we have a chance to touch on the topic. So we're very grateful to both of you for being here and for engaging in this conversation. And as I said in my introductory remarks, Gail, I think maybe before you arrived, we really do appreciate the back and forth that has gone on between the panel participants and OHS about how invitees were identified, what the tone and tenor of the conversation would be, what were the topics for the conversation. So we are really looking forward to hearing your views and getting to solutions. I think in the previous panel, we identified a couple of areas that are going to be fruitful for pursuit going forward that we might be able to look to around lowering drug prices. And so we want to hopefully get to the same with you. So our co-moderator for this panel, I'd like to introduce Frederick Casati. Frederick is the Executive Director of Families USA, which is one of our country's leading nonpartisan, nonprofit healthcare advocacy organizations. And Families was established to ensure that healthcare is equally accessible and affordable to all. Frederick is a national thought leader and subject matter expert on the issues and solutions related to driving value and equity into healthcare and providing high quality coverage. So Frederick's got a couple of introductory statements that he'd like to make, and then we'll turn to the two of you and jump right into questions. So Frederick.
Thank you so much, and I'll take a couple minutes just to put everything in statement. And so, Executive Director Gifford, it's a pleasure to join you at this important hearing and in support of your work. Governor Vermont's work and the Connecticut Office of Health Strategy are undertaking to address the healthcare affordability crisis facing the people of Connecticut. This is very hard work, and I commend you and your team at the Governor. Today's hearing is urgently needed. Americans across the United States, including here in Connecticut, are experiencing a severe healthcare quality and affordability crisis. Everything should have high quality, affordable healthcare that keeps them healthy and allows them to see a doctor when needed. Yet nearly 4 in 5 residents in Connecticut are concerned about being able to afford their healthcare, and nearly half, and we've heard it before, but it's really startling, half report delaying or foregoing care because of cost. That is much worse than national average. There are many reasons healthcare costs are spiraling out of control, both here in Connecticut and around the nation, and it is a very complex problem. Today, these series of hearings are addressing key drivers of healthcare cost increases, and the data and the research are very clear. One of the very significant contributors to the crisis for Connecticut families is the rising price of hospital care. Unbelievably, in the last 5 years, Connecticut hospital prices have increased by almost 50%. And for emergency hospital care, they've increased by nearly 60%. This is totally unsustainable. Imagine what it would be like if the price for our family car went from $25,000 to $37,000 in just 5 years. There are many reasons for the increases in hospital prices, and today's hearing allows us to have dialogue directly with two very large health hospital systems in the state about their price and cost growth. And it's always really important to ask, for all this money, what kind of quality of care are we getting from the good people of this state? Compared to other wealthy nations, we spend much more on hospital and other healthcare, and yet we are much more likely to enter the US healthcare system and die when our lives should have been saved. We continue to struggle with iatrogenic sepsis, MRSA, and other hospital-acquired infections, and our moms and babies are dying at 2 or 3 times the rates of other wealthy nations. The state of Connecticut is taking important steps to begin addressing this crisis, including establishing the statewide healthcare cost growth benchmarks, all with the goal of slowing the growth of high and rising healthcare prices and ensuring that the people of Connecticut are getting the highest quality and most effective care. And I just want to conclude by saying the American people want this action. Polling shows clearly 3/4 of families across this nation of all political ideologies know that we are not getting value from the healthcare sector and believe it's the government's role to get in there and stop all these price increases. I really want to thank our panelists for their time today. Thank you for your hard work. Thank you for everything you're doing on behalf of your patients and their families. And thank you for being here and being part of this session. This is hard stuff. And without a doubt, we have to get this together. It's the only in a sincere and data-informed dialogue with the healthcare sector that we can really ensure that families in Connecticut can live their healthiest life and receive affordable high-quality care. So thank you very, very much.
Gail or Jim, did either of you want to make a brief opening statement before prioritizing all these questions?
Thank you, and good morning, and thank you for the opportunity to be here on behalf of the Yonge and Haven Hospital. My name is Gail Kozlov, the Chief Financial Officer. Yonge and Haven Hospital was notified by the Office of Health Strategy that was found to be a significant contributor to healthcare costs and growth in the state of Connecticut in the calendar year 2021. While Yonge and Haven Health appreciates the work of OHS and support of statutory objectives and our mutual goal towards advancing affordability of healthcare in our state, we disagree with the conclusion. As referenced against the healthcare cost growth benchmark defined by OHS, Yale New Haven Hospital's total commercial experience in 21 did not reflect the trend calculated by OHS and therefore was not, based on the definition set forth, a significant contributor to healthcare cost growth in Connecticut. The calculation that we saw of cost growth for Yale New Haven Hospital captures only total payments made to Yale New Haven Hospital for inpatient care, commercially insured patients. That is approximately less than 10% of our total revenue. And basically took that payment amount and divided it by the number of patients that we're seeing each year and compared them to. OHS implies the singular calculation, again, less than 10% of our revenue for payments is evidence of the hospital's driving up the cost of care. In addition to the source data being complete and the use of only this small segment of the population, there are other challenges with the methodology that misrepresent the calculated results. The hospital's negotiated rates, we negotiate rates with the commercial payers, and I will tell you for this period of time, 20 to 21, the rates that we negotiated were less than the amounts that are indicated in the cost growth benchmark. We also, we receive care and it's adjusted based on the illness of the patient. And we had a lot of things happening between 20 and 21 that affected the illness level of the patient that we saw in the hospital. And I'll point to two things, and those adjustments are made consistent with Medicare effectively. There's a weighting that is based on the level of intensity of that patient across the United States, so it's not just based on our hospital or the state. The types of patients at higher acuity, so frankly, in 21 versus 2020, patients were sicker. And two main reasons for this, and I'll refer to my colleague who was more clinically oriented. But the two reasons are that in 2020, during the height of the pandemic, patients were putting off care. So they weren't getting the testing needed, they weren't getting the diagnostics necessary to get early treatment. They delayed those services into 21. So we found that patients were sicker in 21 than they had in 2020. And I will also say that driving the costs downward was going to create higher payments on the inpatient setting. And that is because as we drive patients to lower cost of care services on the outpatient setting, that is going to keep the more intense, sicker patients on the inpatient side. So you're getting a higher distribution of acuity on the inpatient side. And so by only looking at that data set, we're significantly misrepresenting what is happening to the cost of healthcare. I will say, just in closing the opening remarks, that we contribute heavily to lowering the cost of overall cost of healthcare on a macro level, and I'll talk more about that. But this is not the way to go about identifying the cost.
Thank you. Jim Curran, I'm a non-invasive cardiologist in practice here in Hartford for 30 years. Had the honor of working with Hartford Healthcare as their executive vice president of clinical integration now for 10 years. As we've worked to transform the delivery system to really focus on talking about access to care that's equitable, affordable, and with consistent excellent quality across all the communities. We were asking information to participate because we were found based on the data set on the APCD, which really does only represent 30% of our discharges from hospital Central Connecticut, which is a hospital in Connecticut. That are year-over-year increase between 2021 7.5%. And that was based on a payment per discharge. So to start, if you'd indulge me, I want to do a bit of a thought experiment, because I think this gets all very complicated with price, cost, revenue. We throw those terms around, and oftentimes we're not really understanding what. So let's just say in 2020, I went to the grocery store and bought a bag of groceries. And that bag of groceries cost $100. And I bought 10 items. Therefore, the average cost per item is $10. In 2021, I returned, bought another bag of groceries. That bag of groceries cost me $200. I also had 10 items, and therefore the average cost per item went to 20. 100% increase year over year. And the question is why that go up? I can answer that without knowing what's in the bag. Right? Did you buy the exact same items in 2021? Did you buy the same quantity of those items? Did you in 2021 decide that, you know what, the lower cost fruits and vegetables, I can get my local farm stand. So I'm not going to buy them, I'm going to buy just the other things that I need to buy. And that therefore takes out of that the lower cost items, therefore the average cost is going to go up. The last piece is any price increases that do occur. You have to understand what's driving those. What did it cost me to acquire the groceries that you're buying? What's the acquisition cost of the stuff you're buying? What's the staff, the lighting, the utilities that are responsible to keep the grocery store? If we don't understand that level of detail, it's nearly impossible to start digging in and figuring out what are the mitigating strategies that we're going to do. And I can tell you that the data that we have doesn't supply any of that kind of information as we go forward. So if we flip that, the analogy isn't perfect, but it allows us to kind of sort out when we talk about patient mix and patient mixes and all sorts of things. It's really important to know what are the drivers of increasing cost to the consumer who bought the bag of groceries. What's in the bag? For hospital, it's the demand, which we know is continuing to increase and is not being met adequately. It's patient mix, disease burden matters. None of us would say that a healthy Jim Carter who goes in for a gallbladder surgery or an episode of pneumonia is going to have the same hospital course or costs as a Jim Carter who's got early dementia, heart failure, and stage renal disease, who ends up with the same pneumonia or going through the same gallbladder surgery. It has to be accounted that the disease burden of the patient has got to be incorporated. Also, what are the services the hospital is administering? If the hospital is doing a whole lot of cardiac bypass surgery and appendectomies, and remove the appendectomies, price just went up per average because we're just doing higher cost services. So it's really important to think of that. Lastly, the entire area. We have to incorporate all the different payers we have and figure out what that costs. Until we dig into that kind of detail, it's very hard to know where and what we need to do about it.
Thank you both very much for those introductory comments, and noted. One of the things that we said this morning was that, you know, OHS, this is our first hearing and our first walkthrough with the identification of individuals to invite. So we hear you on the risk adjustment, and we of course hear you and acknowledge that 2020 and 2021 were not your average years, to make the understatement of the century in the healthcare system. And we very much appreciate the dialogue that we've had with you and your colleagues about these issues, and we want to continue those. I know that our colleagues in Massachusetts are doing some work around this issue of risk adjustment. And they're having some interesting findings. We look forward to working with them, sharing their findings with you. And but we don't disagree that unpacking some of these things is going to be essential to understanding how we're going to drive down the cost of care. We are doing some additional work looking at trends in some of these issues. We also want to understand what's happening with coding and case mix adjustment. So more work to come there. What we like to do, of course, as we've been talking about, is understand the drivers of hospital costs and what we're going to do about them for the future. And I know from previous conversations that both of your organizations have thoughts about how to do that. So I'm going to turn to Frederick now to begin.
Thank you so much. And I just want to say I do testify myself in Congress, and it's nerve-wracking. We gave you some questions in advance, and we know we're going to kind of go beyond them. So it is perfectly fine. It's a good question. We'll get back to you and come back to you. That you should definitely feel free to do that. And to this point, you know, ultimately, this is the really hard place that people, families in Connecticut are in. Which is you're providing a lot of different rationales for why. You may see the per charge amounts going up, the per discharge amounts going up. But we do know, you know, that the costs here are higher than in the United States for hospital care. We also know that over the last few years across the country, hospital prices have gone up 4 times faster than people's paychecks, right? And I think I just want to start with saying, you know, as a general principle, if the price for cost of hospitals are going up faster than families' paychecks, do you see that as an unsustainable dynamic?
Oh, absolutely. I don't think there's any question that we spend every day thinking about what's driving the cost of care. We've been on a plan trying to figure out what's actionable and what we can do to improve.
And do you see that, you know, both of you are nonprofit organizations. Do you see that, you know, the idea if you can't afford care, then it's not accessible, right? So do you see that as part of your mission to make sure that the care that you're providing is affordable to your patients?
Yes, and exactly your point. As patients don't afford it, they end up presenting with more complex care, needing more intensive therapies that results in driving costs up, which again, we are constantly looking as to how do we provide that level of care as efficiently as possible. But you can't divorce it from the fact that sicker patients are ending up in your hospital. And regardless of, the intentionality of what that means, costs are gonna go up when you're dealing with sicker patients providing more therapies and more complicated surgery. It's an inevitable, path. And as we do things to try and move lower cost things out of the hospital, the cost of what's gonna reside back in the hospital is gonna go up. In HOCC, that was very intentional. We went through a process over this period of time of increasing the need to village back hospital to deal with more and more sick patients, and so it's reflected in a lot of the data. Thank you.
Yeah, and I would just add that I think, certainly, the comments that you made, I think we're all interested in affordability of care for our patients and for our communities. As not-for-profits, we have as our mission to provide care for those regardless of their ability to pay, and we're compelled by various statutes to do that. I mean, certainly when a patient arrives in the emergency room, they must be seen and treated. There are criteria for admission. There are criteria for, you can't admit that patient, you need to observe the patient, sometimes an observation is 72 hours. So, there are a lot of criteria, but I think the base of the mission to care for people regardless of their ability to pay, that is not necessarily shared with all healthcare providers, particularly those that are for-profit activity-based healthcare providers. And so, as you see the same with the technology moving patients to more or to lower acute levels of care, and that's raising the cost in the hospital, you're also seeing commercial patients that have insurance. Those are being, those are going to those private healthcare providers, and what's left in the not-for-profits sometimes are underpaying patients, uninsured patients. And many times those patients without a managed care program are sicker when they're arriving, and with less ability to remain compliant because of social determinants of health. And I think those are all areas on a macro level where we're doing a lot to address those costs. When the patient arrives in the hospital, we provide them reporting.
Excellent. It'd be great to hear that you guys are looking at social rights. We know about 80% at least of our health is about that and not about the care we're getting. I wanted to kind of dig a little bit deeper into the growth of possible cost and prices. And across the nation and here in Connecticut, one of the main drivers of price increases is lack of competition. There's so much literature on this. And as local hospitals merge together and eventually with corporate hospital systems, we see prices going up and up and up. To what degree have your health systems been engaged in these kind of horizontal mergers? And what's happened to your growth in net prices after the mergers?
Well, first, I don't see any evidence in the data that's occurred. So out of the gate, as much as that you're seeing an increase in negotiated prices as a result of the actions of the bill.
It's on average about 30% increase.
Yes. No, this is growth through. We have to be careful. We talk about prices and the cost of delivering that care. They are not the same. When you look at your own data on what we have, when you do a simple case mix adjustment, Hartford Hospital Center, Connecticut increase is 2.7 across Hartford Healthcare. The increase was 1.7. So I don't know where we're coming to the conclusion that first of all, the negotiating prices. And I think we have to be careful when we use, in my view, what we're talking about becomes essential to make sure we're really getting to the cause of the increased cost to the consumer, what the bag of groceries cost versus what was due to a price increase on any individual component. And right now, to date, we don't see any data how this relates to negotiated pricing.
There's a lot of literature on this, but
I'm curious.
well, that's sort of the question we're asking. So first of all, have your health systems engaged in this kind of horizontal consolidation?
Oh, we absolutely have. We have absolutely continued to grow as a system. because of the benefits that systems have brought to the communities we serve.
And I would say, answer the question also in the affirmative, yes, because it is very difficult for hospitals because of the synergies that can be made across the board to survive on everything. You see a lot of hospital closures across the country because of that inability to survive, but it's not on pricing. It's on efficiencies of overhead efficiency, building operations, back office, things that can be gained through those consolidations. And I do not see evidence of using that as leverage for this in our research, and that may be across the country, but that's not here.
Can you provide, just say, for example, your inpatient procedures that increase the most in price, just give us what the top 5 have been and what that change occurred pre and post merger. So you can actually see, did we see an increase in this because competition went down and at a higher price to the chart?
I think you would have to look at the services that went down. I mean, the joint replacement, something that was done on that inpatient side only, and is now an outpatient service. There are a significant number of procedures that have gone down.
Well, that's a great point. You do see a migration from an inpatient into an outpatient setting. That's another kind of consolidation that's happened in the country, which is vertical consolidation. And what we're seeing is that a service that was traditionally provided by a physician in our office, all of a sudden is now part of the hospital outpatient department. And we see prices increasing, as you point out, I think fairly, the price between an inpatient procedure and outpatient procedure goes down. But the price between the physician service in our office compared to being part of the hospital outpatient department goes up. And a big part of this increases are what a lot of people are talking about, which are facility fees. And we see, for example, the underlying service to get MRI that might cost a couple $100 has $1,000 facility fee that's included. It's 4 times or 5 times more than the cost of the actual service. And that would be an example of the way that vertical integration is increasing prices. So have your systems engaged in that kind of vertical integration?
So we've been very purposeful in developing our AMS right now, but very different than saying we're adding to hospital outpatient. These are centers that are non-hospital outpatient. We've got in the HOCC service area, we've opened up 7 ASCs. These are ambulatory surgery centers. We've opened urgent care 10 locations, which have had a significant impact on our ED utilization. Our ED utilization has decreased 7.6%, 19.2, with and then the non-hospital imaging centers. All of that very purposeful for us to move care from inpatient to ambulatory settings across our healthcare. 40% of our services, all surgeries performed, are now performed in one HOPD ambulatory services, which are substantially lower cost. We're seeing almost 300,000 urgent care visits, and that's resulting in a 10+% decline in low ED business in our ED. This is all part of the strategy. Yes, something a system can do to bring forward lower cost access points of care that really will help manage the total cost of care. But the impact to inpatient is going to be very different. And this is the problem if you're looking at just inpatient, because if you're holding to that inpatient measure, you're going to be disincentivized to start moving lower cost care out of your hospital because it's lower if you're eating the fruit and vegetables in the bag. The other thing is you're going to see people who say these patients are really complicated, we're transferring them out because I'm not going to provide that care. That's not what we're doing. We're actually enhancing services.
It sounds like you're really highlighting that in some ways, the underlying economics of being able to run your health system, there's this tension as you pull patients out of the inpatient setting, it might be more expensive and provide high quality care in an outpatient setting. You then threaten the viability of your inpatient services and might have to increase prices. Well, I think you said you might have to increase prices to account for the low supply.
You know, what I'm really saying is that remember what's going to be left. The prices will go up simply because we don't have the simple low-level vegetables. We didn't increase the price of it, and you could do that without any price going at all, because you're averaging it over the cost of the services. So as you incentivize people to have their care out, as you take out all those lower-level surgeries, the complicated sick people remain in the hospital. No price increase, but your average cost just went up quite a bit. Use the thought experiments. I have a hospital that does cardiac surgery and appendectomies. Average cost is a blend. I take out the appendectomies. The cost went up. I didn't do a single extra surgery, nor did I raise the price. It's
Yeah.
really important to have a concept.
Agreed, and so I wanted to, I'm just interrupting Frederick for a minute, because I wanted to get this takeaway into the minutes of the proceeding. This issue that you're bringing up, that as we think about hospital prices, we need to look at the combination of inpatient and outpatient, right? You're saying, look at the total, don't just look at the inpatient. Fair enough. Our data so far show both increasing, right? Jim, you and I had this conversation earlier, which is, you know, if we're taking the very fair point you make, which is we're taking the less sick patients and we're providing the care in outpatient. By definition, we're going to have sicker patients on the inpatient, but we should start to see a shift of lower overall utilization on the inpatient side that is not fully replaced because they're lower cost, less sick patients by the outpatient side. So your point is well taken. Yeah, hold on one second, I'll get to you. Your point is well taken. We need to look at both. And I want to just make sure that we take away at OHS and at Baylor, and I know we're already starting to do this work with our partners at Mathematica, this issue about the sicker patients shift from inpatient to outpatient. And in fact, you use an app now because we are creating a market basket that we're going to track over time that's standard. So it's not switching from fruits and vegetables, you know, to bottles of expensive brandy. It's we're going to track the same fruits and vegetables over time. So that's a takeaway for us collectively, is to explore this issue of inpatient versus outpatient and to make sure we're tracking market patterns over time.
If you could, just make sure we differentiate hospital outpatient versus ambulatory surgery, because the ambulatory surgery right now has not been picked up. And you keep the hospital outpatient piece is yes, even including that, will give you some sense. It's the ASCs that right now is at a food stand and nobody's down at all. And we have to really make sure we have that.
Gotcha.
And I think by the same token, on the outpatient side, if you start to shift some of those high intensity services from a status of inpatient to a status of outpatient, you're gonna see the mix change there as well. So, you know, I really think the mix of services, and I would just say the overall type of service provided. So, you know, we talked about and I love the analogy of the grocery basket here, but you also gave the analogy of the cost of a patient with several comorbidities being extremely different than someone who is otherwise healthy. And the intensity of care that goes into that, as well as, you know, with some population, their adherence to or compliance to post discharge reconstructions and things like that, I think back in the hospital, those are things that are accounted for in the data in terms of the case mix, but not reflected in this comparison. And just to add to your analysis that you did for Hartford, the same is true at Young Haven Hospital and health system at large, is that when you take that acuity down, it's flat in terms of.
That makes sense. Let me ask you what, just before we leave this topic, I do, you know, the question of a physician practice being purchased, you know, part of the hospital outpatient department, and then all of a sudden, very large facility fees and other things get added in. How do each of your institutions, how do you establish your facility fees? And how do you audit them to make sure they're reasonable? Because there's so many people, so many families here in Connecticut, across the country, who go get that MRI analysis and see this $1,000 fee, and like, what's going on here? So how are they set, and how do you audit them if the reasonableness for actual sounds?
Yeah, I mean, I would say that the acquisition of a physician practice does not entail a change in pricing or rates, there's no facility to charge for an office visit. I think for settings of services, there's a difference, it's a split fee versus a bundle fee. Facility charges, there are costs associated with when you code the bill. The physician is a place of service at the hospital, and the hospital has requirements, regulatory requirements, staffing requirements, et cetera. We are very deliberate about our stuff to ensure that it makes sense for the type of service that was being offered. And we understand that patients have choice and can go to lower levels or lower cost services for the same services. And so we're being deliberate about that pricing to ensure that we're not pricing ourselves out.
So can
I
you,
would also like to add that, in terms of patients and policies for collection and things like that, we are very liberal with the policies to ensure that, again, we're meeting our mission that patients can't afford the service that we've got programs.
so it would be great, it sounds like it's a very deliberative process, if you could provide a detailed description, how are these facilities going to be set? And how are they audited to make sure that they're reasonable and not abusive, that's. And just as you're, picking up this question, that it's a really important one. I was really struck by the fact that here in Connecticut, a third of the families in the state are really struggling to pay for their healthcare bills, and many are going into debt. And that's kind of, it's a huge burden for families. So how many patients, total number and percentage of your patients are actually sent to collections after receiving care at their facilities? And also, what's the relationship between the collection agencies and your facility? For example, do they purchase a debt from you? Those sorts of things.
I could not quote numbers, off the cuff like that.
That's
but
fine.
it-
If you can
But-
provide it here, it's not.
If I can say, we have income-based programs for patient responsible balances that are extremely liberal. Those are publicly shared information that, I believe that we are very liberal with respect to these policies. We do not credit report, and we also do not sell any accounts receivable.
We have similar policies to ensure that for folks who cannot pay, that we ultimately work with them if possible, but do not send them credit agencies, their credit rating. We don't send them to collections and even purchasing to get to see that's importantly as well. This is part of the uncompensated care that as we talk about understanding as we bring this data forward with all payers, what that looks like, as well as all the costs that we incur to deliver that care. That's where this needs to start getting much broader insights to what that entirely looks like. Because the more we segment it down, the more you end up with data that is not intentional, but ends up informing decisions and mitigation strategies that don't pay.
Right. Well, I think that's great to hear. It does kind of give some great policies. I think in particular, you can provide information about percentage of your patients who are actually, you are seeking additional payments from, they're submitting a bill, they're having to either make, installment payments, those sorts of things. And the second piece of it is, how much of that bill is the original charge versus interest or other kinds of fees. Just if you can provide information so that we can
Provide that right now, it's 0.
Okay, it'd be great to see that in terms of the percentage of patients who are going through that experience. And then
We do not charge interest or collection fees.
that's great. And it sounds like you're going to sell your debt, which is also excellent. Just understanding what percentage of patients are going through the experience of having the installment payments. And, I think that helps us understand to what extent your charity care policies are actually working and how many families have been stuck paying a bill for, decades, that's
I'll just interrupt it and say that installment payments are available for just about anybody, so it would be very hard to see whether they meet an income requirement and they're paying that because, so we offer no interest, no fee installment for just about anybody who requests that. So it would be hard to tell whether somebody's doing that just because they like to use their money for something else.
But then it would be hard to know if your policies are working and your family's just going straight to installment payments. You
Well,
don't know.
we know it's working because we know people applied for it and meet the criteria and we're providing, adjustment.
It would be helpful to know as an advocate, right, what experience your patients having, how many are on those installment programs. Just so that we have a sense of, the installment program is a pretty good indication that they can't afford to pay the bill up front, right? So they're making installment payments.
With their deductibles and everything else, it gets, as stated, that the higher the deductibles that patients have, they don't always have the cash flow.
Right.
So they can meet, they may say, right, I think local practice, we certainly like meet the obligation that you're held to when we purchase this plan, but we just need time. There's no question that there's no competition.
Right. So the next set of questions are really just about the kind of underneath this all within your health system. We know that there is a huge crisis for families that can't get around in care. We know that hospital prices are going up, faster in other states, neighboring states. And this is a shared goal you are very concerned about people that with your care. You're very concerned about as part of your mission. So in that spirit, and also as you talked about quite eloquently, that you're providing high quality care and you're really addressing health needs of the patients. So I think the first question is really about, for all the money that's being received, when you think about the ways in which you incentivize your physicians and your C-suite folks, what specific links are being made in your compensation structures between the quality of care being received, the affordability of care being received, and compensation that the leaders in the health systems are receiving? Specifically, what percentage of the compensation they're receiving is literally tied to either quality or really ensuring affordability?
Several different, let's start with the providers. There's no question that clinicians all have as part of their comp model a component of both productivity and quality that they
Usually just
depends on, especially depends on the
a rough
physician.
estimate.
It depends. And
Sometimes
there's no,
it's 90-10, it's 95-5. I mean, it's a very small, 95% productivity meaning volume, and then 5% quality.
and there are times where it depends on the provider, it depends on the specialty, so there's no general one, that's one. Two, we are currently in significant downside risk, which allows us to really focus on that, both in terms of Medicare Advantage and care plan that we have jointly developed, as well as a risk-bearing entity. We'll have somewhere in the order of 50 to 60,000 lives that are full up and downside risk, of which our providers are performing with quality to where they can earn some incentives around, as well as.
That's very exciting. The downside risk is really critical. It's aligning the incentives of your health system with your patient's health and financial security, things like that. What percentage of your book of business does that downside risk?
Well, this will be our all Medicare Advantage plans. So it's we just started that plan, the risk bearing in January of this year. So it's from, we'll have, as I said, for 2024, 50 to 60,000 lives.
What percentage of your book of business is that?
When you're talking about attributed or people we care for thousands of people every day.
Sorry.
But they're not necessarily attributed to us.
We're talking about economic incentives, right? So in order for this to work, a very large percentage of your net margin has to be tied to that. So I'm asking, if you book a business, so if you're making $100 a year, what is it, $10? Is it $20 of your total revenue from the is tied to this?
It's not that easy.
I think it's sort of an important number because that tells us your economics are really changing, right? This is 10%. Everything you're doing to try to align incentives and improve quality may actually be hurting you on the other side. So
Can I just make a comment on risk?
Yeah.
So since the 1980s, health systems, hospitals have been reimbursed on a a case rate for inpatient care. All of our contracts, substantially all of our contracts at this point in time are based on case rate of care. When a patient comes into the hospital and is admitted to the hospital. We are on the hook, so to speak, from the downside or upside for all of that revenue, all of it. So the patient that comes in with the comorbid conditions, there's some slight adjustment for that. But the patient that leaves and is not compliant and comes back, we're on the hook for that care. So that is why you see in periods of time where there's a change in mix, a change in payer mix. Hospitals across the country are losing a lot of money on an operating basis. And that is because we are not adjusted based on the cost, the internal cost of our care. There's no adjustment in those services. So we have a significant downside risk with respect to all of these patients.
Well, I mean, to your point, right? If you have a patient who comes in and receives, and not only slice, I know, because receives poor quality of care, gets discharged, goes home, 3 months later shows up and needs more care, that hospital will be more money.
There are readmission criteria for mostly all of our contracts regarding that particular patient that you spoke of. But we'd also there would be quality indicators that.
Under the risk model, you would be on the hook for that person coming back. So there's a difference in the economics between the case that you're describing and the risk-based payment. And hospitals that may have people coming back.
Understood. There are various models, but the minute the patient comes into the facility, we are at risk for that patient. And we take that very seriously, and we have great quality indicators to back up the quality of care that we provide within the hospital.
So just in my role of noting things for us to talk about in the future, I think this line of questioning that Frederick is pursuing is really a fruitful one for us to talk about. I know the work that Harvard Healthcare has been doing about risk-based contracting. I'm less familiar, Gail, with what Yale New Haven Health is doing. That doesn't mean it's not equivalent. I'm just personally less familiar. OHS is going to be undertaking for the first time this year a survey of payers to understand what portion of their book of business is in some of these advanced payment models. But I think understanding it from the provider perspective, from the large systems like yourself, will also be really helpful for us as policymakers to understand how is Connecticut doing in moving towards some of these more value-based payment strategies. So I'll make a note of that as a place for us to continue the conversation. How can we explore more how you're progressing down that path from straight up fee for service to more value-based payment? So thanks for bringing that.
And I think just to wrap up this line of questions, I think, a lot of us have worked in different kinds of businesses. And one thing for sure that drives outcomes in employees is compensation. And so, in particular, it would be really important to know how your compensation is structured to incentivize students' quality and affordability. And as you point out, sometimes it's a productivity measure. In many places, that's most of the compensation is based on financial volume, right? How many people you see. And in particular, as you guys both said, it's a big part of your mission and the work of your organizations to make care affordable. So in particular, we've got a C-suite here in Connecticut, $8 million a year in the health system, right? How much of those $8 million are being tied to improving quality and affordability versus increasing prices, increasing volume, and those sorts of things? I think that's really important. That lets us know you guys are really serious about affordability and quality as opposed to just more and more revenue.
Yeah, I mean, I would speak for our health system. Incentive comp is for this suite is a balanced scorecard, and it is heavily included in value quality. So there are components of that. All as a non-for-profit, all of our salaries are at fair market value for the types of services and the individual that is needed at home. So it is also a regular.
Right. Yeah, so a significant amount of compensation is at risk, truly at risk, based on performance around quality, safety, experience, equity, and all of the salaries obviously go through the same fair market value sort of justification.
Okay.
But it is a substantial.
Right, and these are very, formulas, right? So getting it, being able to see exactly how the competition is structured and seeing the ways in which quality and affordability are weighted into those tells us a lot about the commitment within the organizations of affordability and quality.
So we have five goals that we our incentive comps broken across those, and those are really around both quality, which includes both inpatient and ambulatory quality measures, with clear metrics and goals. The second is really equity, it builds having various components of addressing equity. In our quality goals, we have a component that's based on performance around what our diabetes score, have the symptoms, then we have to make sure we get a system in terms of the ability to close those gaps in their patient experience, physician experience component that built in as well as this protocol.
And those sound like excellent metrics to be utilized. I think the weights really matter. How much is one weighted versus the other, and
Equally rated across all of them.
so it'd be great to see that actually the formula, right, and see how it's applied.
Yeah, we have all the same programs, but I just want to go back to your question on value-based care and its contribution to lowering the cost of healthcare. There are several other initiatives that hospitals and health systems in the state are embarking upon to improve the affordability of care and lower the overall cost. You mentioned value-based care, I think that's one. Investment in primary care is another, collaborating with our federally qualified health centers, public health initiatives. So, all the work that was done with COVID-19 in terms of, identifying testing, identifying vaccinations, all of the research, all of those are costs that they're not singularly reimbursed in the way that we think of in terms of services, developing care pathways within our electronic health record and the investment in our health record to ensure non-duplication of services and reducing the cost of having testing so that when you go to a primary care and you go to your specialist, the specialist can access the same set of tests and doesn't have to order new tests. The amount of investment that we make in research around pharmaceuticals in connection with Yale School of Medicine and new therapeutics that get to the level of service where we can move patients out of the inpatient setting into the outpatient setting and actually prevent the disease altogether in terms of services, the lack of services that may be provided in the future because we're able to prevent that completely. But then also managing care, you mentioned social determinants of health, all of those go towards reducing cost of healthcare.
Yeah, and those are some of the really wonderful programs, and it's important to highlight the way the roles that health hospitals can play in all of them in critical ways. And these are very important community resources that you're describing. On the other side of the equation, we have really, and it's worse than the national average. You've got the people in Connecticut who are very worried about affording health care. You've got half of your residents who are foregoing care or skipping care because they can't afford to get it. And we know that the hospital prices in this state are higher than in neighboring states. So there's a real concern there. And I wanted to give you guys a wrap up question because we're just at the bottom of the hour, which is really, I think I really do applaud the office and government for taking this on. It's really tough issue. It's very complex issue. There's no question that people of Connecticut and people across this country are really breaking under the burden of healthcare costs. Across the country, hospital prices are going up 4 times faster than people's paychecks in the last 5 years. It's a crisis. So if we're trying to address the price of care being too high and the overall cost of care being too high, what is your recommendation to the governor and to the office and how we can together lower the cost, right? Not the unit cost, but the overall cost of care.
I mean, it's interesting when you were sort of on the last topic, talk about, affordability and the public or the individual being a breaking point. It's just interesting, I think that, and this is one area of much needed collaboration, not only in Medicaid. This is, there is no managed Medicaid in this state. And a lot of the people that you speak about that are at a cost breaking point, they're being driven to higher levels of care because of the lack of state-sponsored ability to receive some of that preventive care. I think that is a great place to go.
Well, just to be clear, Medicaid recipients have no cost sharing, so they have very little cost sharing. They're not the ones who are going to die. They are very, very poor. They have very little resources. They can't.
And all of the programs that we have to assist patients are.
So, and I appreciate the last comment as we look at how we going to get to solutions here. I do want to just again highlight that, and I know you know what you intend to mean when you say hospital price, but everybody else hears reimbursement. They can't be around price per service, and we've already said that right now it is not clear. In fact, there's no data, and there's even your own data that suggests the price per service is not a major contributor to the cost that people are incurring to receive care. There are all sorts of other drivers, and we keep kind of jumping past it. I know we're going to incorporate this, I'm hearing you, but until we dig into the drivers of what's actionable and what's not, and who can create those actions, we're not going to be addressing what's driving the overall rise in healthcare cost. What's in the bag?
That's such a fair point, and I think you made it really well, right? So, but the other side of the problem is, particularly the governor, the state legislature, and the office is the families are getting their hospital bills, and they're seeing that those bills are going up, and they're seeing those facility fees, and they're seeing the really high cost, and it is breaking them. So when you say it's not the prices are high or not right, it's not acknowledging the experience that so many families in the state are having.
I am just suggesting that we have to really understand what the underlying drivers. You've referenced it multiple times in this meeting. People are delaying care. Now I know that's an out-of-pocket expense issue. What they end up with is sicker care in the hospitals. It looks like we're providing it, but it's the result of very much a different set of circumstances. SDOH challenges. Driving, there's no question we have major access problems in this state. The demand keeps coming. It's not the lack of trying to fix the access problem. Yes, price is part of it. Part of it is just really hard. Anybody who's trying to get an appointment, it's increasingly difficult. We've added a host of 90 primary care, new primary care clinicians, increased our primary care capacity over the last 4 years. Still can't meet the demand. So that there are real challenges that's going to take a much broader engagement and getting agreed upon data so we all know what we're talking about to get to these solutions. If we hadn't, I know, believe me, as chairman, I wouldn't be sitting here. But the bottom line is that that's the kind of work that really has to be done and make sure that we understand what the data is telling us and what's not, and where are those actual steps and who are the different parts to follow.
Thank you. So, I'm thinking maybe we ought to think about stuff through. Don't quote me on this, even though I'm now being recorded. I'm thinking maybe we ought to think about a subgroup that is going of the steering committee that's going to look at this issue, Dr. Carden, that you're bringing up, because our data in the APCD do show a price paid per admission going up year over year. And we've had multiple conversations with both your organizations saying, you're wrong. And so we do need to get to an agreed upon set of facts here on this issue. So I think there's some fruitful conversation to be had about how we're going to get before we get to next year's report and hearing, how we're gonna get to that, and we may just end up agreeing to disagree. Or we may further illuminate, you know, why you have a different view than the Office of Health Strategy. I want to thank you both again for your really constructive participation. I think we started to touch on a few issues. It's obviously a huge body of work that we have to do together. We were never going to get to all of it in an hour. But, and I know that these are difficult, challenging questions, and we appreciate your willingness to engage in this back and forth to help the office, to help the governor, to help all of us think through getting to solutions. That's why we're here. It's going to take these tough conversations. And so we appreciate that you're here and willing to engage. And I want to thank Frederick for making the trip up from Washington and sharing the views of your organization and helping us think through the appropriate questions. So with that, I think we're ready for lunch. Okay, so we'll break until 12:30. And hope to see everybody back for the insurer panel. 1:30. 1:30.